So in case 4, an unidentified male with multiple gunshot wound was airlifted to a trauma unit. He was initially admitted in a community hospital and received several units of blood. So the following are his results. So we have here in the forward typing, we have anti-A, we have a mixed field result, and then in the anti-B, we have 0 or negative. Anti-AB is 1 plus. In the reverse typing, A1 cells is 0, and then the B cells is 4 plus. Then the RH, it shows also a 1 plus reaction, which is also part positive. So what's the discrepancy? There is a mixed field reaction in forward typing with anti-A, while the reverse typing clearly shows strong anti-B or 4 plus reaction and no anti-A, which is consistent with your group A serum. Normally, a true group A person should show strong reaction with anti-A in the forward, and then in the reverse, it should be anti-B only. So instead, the forward typing shows weak or mixed anti-A, creating an ABO discrepancy between forward and reverse results. So the patient received several units of blood before testing. Massive or recent transfusion, especially with group O red cells, can cause two red cell populations in circulation. So patient's own cells, such as group A cells, and then the donor's transfused cells, group O cells, when tested with anti-A reagent, so the patient's A cells agglutinate, the donor's O cells do not. So this produces a mixed field appearance, some clumps and some free cells. So reverse typing is unaffected because it tests patient plasma, which still contains anti-B antibodies, so giving a strong 4 plus reaction with your B cells. Thus, this is a type of group O, type 4 ABO discrepancy, or the miscellaneous cause due to recent transfusion producing a mixed field agglutination. So how are we going to resolve the problem? You're going to review the transfusion history, confirm the recent transfusion, then repeat testing after washing the red cells to reduce donor plasma interference, and then we can obtain pre-transfusion sample if available, and then perform patient history correlation in which the trauma patient receiving emergency blood. So this confirmed that the mixed field reaction is transfusion related. So the correct blood type of the patient, it's blood group A, RH positive. And then the last case that we have, a 45-year-old woman was admitted for hysterectomy. The following is the result of the pre-transfusion testing. The antibody screen was negative with no history of any clinical significant antibody. So for forward typing, anti-A is 3 plus. So A antigen is present, anti-B is 0, then no B antigen is present. So anti-AB is 4 plus, so this confirms the presence of your A antigen. So the forward typing indicates the group A individual. So in the reverse typing, A1 cells is 1 plus, unexpected weak reaction. For the B cells, it's 4 plus, which suggests that anti-B is present because the reaction is strong. Reverse typing mostly supports group A since anti-B is strong. But the 1 plus reaction with your known A1 cells is abnormal. In the RH typing, the patient is RH positive. So the control is 0, so it is a valid testing. So what's the discrepancy? A true group A patient should show anti-A positive. B cells also, known B cells also is positive. However, this patient shows a weak or a 1 plus reaction with your known A1 cells. That means the serum contains an antibody reacting with your A1 cells. So this is unexpected for a typical group A individual. So what's the cause? So this pattern strongly suggests anti-A1 antibody in a subgroup of A, most commonly A2. So some individuals are not A1 but A2 in their subgroups. So A1 and A2 are subgroups of group A. A2 individuals lack some A1 antigens, so that's why from our previous discussion, about 1 to 8% of A2 individuals produce anti-A1. Anti-A1 reacts with A1 cells in the reverse typing. So this explains in the forward typing strong A antigen because A2 still expresses the A antigen. In the reverse typing, it has a weak reaction with A1 cells due to the production of anti-A1. So strong reaction with B cells, it's still normal because your A2 individuals will produce also anti-B. So what's the discrepancy? It belongs to your type 2 discrepancy wherein there is a weak or a missing antibody. So specifically, unexpected antibody in the serum which produces the anti-A1. What is the patient's possible condition? So the patient's most likely A2 subgroup with anti-A1 antibody. Why? Because strong anti-A1, the forward typing, or unexpected reaction with A1 cells, and then it has no history of other antibodies. The antibody screening was negative, And then anti-A1 is often cold reactive and it is clinically insignificant in most cases. So how are we going to resolve the problem? We can test the patient's red cells with A1 lectin or dolichos biflorus. A1 cells will react positive, A2 cells will react negative. We can also test it with anti-H lectin or the Ulix europaeus. A2 cells have stronger H antigens than your A1. So we can also perform reverse typing at room temperature or at 37 degrees Celsius because anti-A1 usually disappears at body temperature at 37 degrees Celsius or if they are cold reactive. So what's the correct blood type of the patient? The patient now is A2RH positive. So again, in order to avoid and resolve ABO discrepancies, you can repeat all the tests, and in order to be sure, you can wash the red cells properly, prepare the red cell suspension accurately, reagents and equipments are free of contamination, check the viability of the test reagents and blood samples to be tested, then no sample mix-up, strictly follow the procedure, and read the results immediately. And with that, everyone, I would like to conclude our discussion with regards to ABO subgroups. So thank you, and I hope that you have learned something from this video.